And I'm going to kind of make a comment that will undermine everything that's just been said, but the legacy of my care is not how many RVUs I created, but the quality of care that I provided to my patients, and that's where my programs come from. So it's the humanity of the care that we want to be thinking about, not the RVUs. And I'm going to show you how you can actually, everybody's going, oh, I'm worried about the economic stability of my organization. But with some fundamental structural changes in the way we think about healthcare and willingness to move to different economic models for reimbursement, you can dramatically improve care for the patient, very patient-centered care, and you can control the cost of care. So this is my colleague and I, and this is what I've been doing for the last, when was the last time I was here, Don?
Probably
two and a half years. 2 years? Yeah, well, I've been at the World Congress of Geriatrics and Gerontology in Taiwan. I'll be going to Fukuoka, Japan. I was working at Harvard Business and all over the country because we've created a different way of thinking. 2 days ago, I was meeting with some advisors in advanced illness medicine and CMMI directors about how to look differently about how we take care of patients. So I'm going to talk today about advanced illness management and the approaches that we can create. Sorry, it's the CME, so I got to put all this silly stuff in here. One of the things you need to realize about me is I've been involved in post-acute care my entire career. 25 years working in nursing homes, a home health medical director, hospice medical director. I've now working as the chief medical officer for community-based palliative care for Sharp Healthcare. But when I started healthcare, I spent 2 decades working as a utilization manager because when I retired from my residency, I'm the kind of guy that looked at the Medicare Trust Fund to see if we were going to survive in this career. And at the time, the projections for the Medicare Trust Fund were whether we had a good economy, moderate economy, or a bad economy. And the sad part about looking at that at the time in 1993 was they all went bankrupt during the time I would be in practice. And so stewardship of our system, stewardship of our career and our profession is a big deal. This is after Obamacare. I don't see any of those lines not saying we're going bankrupt yet. And so I do think that as well as the personal responsibility to manage care, we also have to be stewards with the economic responsibility. I don't believe that margin, no mission, but we also can't bankrupt ourselves in the process because it makes it harder to do what we want to do. So most of you know, it's probably been about 5 years when I came here and did a presentation asking the question, do we really need hospitals? And it was based on an outpatient program that showed that we have a construct problem with healthcare that we use the hospital as a tool to manage patients when that care is absolutely unnecessary. And after about 6 years of that program being up and running and 4 years of it being stabilized, I published our first research article, which was in the Journal of Clinical Outcomes Management, looking at the economic outcomes and the benefits to our patients. I'm not a researcher, so it was quite an experience to go to Sharp that didn't really, at the very beginnings of a research institute, to put something into paper. And this was showed that we could actually decrease admissions for our heart failure patients by proactive management that does not generate RVUs, by the way, instead of reactive management, looking at what patients' needs are. And that was a 56% decrease in the utilization of the hospital and the emergency room by changing the way we looked at the management of care. The California Healthcare Foundation, which I'm a part of, saw the work we were doing and said, well, what if you work with some people who are used to doing this, and they partnered us up with Kathleen Kerr and Brian Castle from Virginia Commonwealth University. Brian has hundreds of research articles looking at palliative programs, outpatient palliative programs, and has concurrent models to provide patients the care that they want. And we published another article that just came out in JAGS, Journal of American Geriatric Society, and that was published just about, 4 months ago, November of 2016. So here's the objectives. I'm going to move past some of this quickly because you don't need to see understanding the methods, observational research, quality impact of community care, palliative programs. I will say this about palliative medicine right now. It is not going to take over family medicine. Family physicians should all be trained in palliative medicine. And palliative physicians should just be the experts you refer to when you can't do basic palliative medicine. That's it. So I don't think everybody, I know there's a shortage, there's only about 6,000 board-certified palliative physicians in the country, and about 2,000 of them don't really practice palliative medicine, so you're not all going to get palliative medicine. But the principles of palliative medicine can help guide people to better medical standards. So we looked at the hospitals, the healthcare systems most likely to implement these programs. Obviously, if it's in their economic interest, we can provide better care, so we work with those programs. We're trying to, Brian was always talking about bringing the clinical model with the economic model. And I kept saying, yeah, well, what about the ethical model? The ethical model is patient-centered care, give patients what they want. So that part's not in there, but that's a part of what I was always trying to bring to this. I will tell you, and here's the first part, people should not be afraid to move into shared risk contracts. Because the cost savings in healthcare that will give you the opportunity to provide better care for your patients, which will decrease your RVUs, is shared risk contracts, so that we avoid care. It's the reactive model that says once we're broke, you fix you. That's fee for service. Versus, well, I know you're going to break, so I'm going to keep it from happening. And there aren't as many RVUs for the second one. So this is the current care for homebound patients. We simply layer palliative strategies on top of traditional strategies. People who are board certified in the issues that are important for palliative management. I have had 2 discussions this week. By the way, I'm a little bit tired. My plane had a hydraulic leak coming out of Houston yesterday. So I didn't get in until very early in the morning. Throw some paper at me if I start to mumble or fall apart. But the purpose of the concurrent program is not to take traditional care away from the family physician or the internist or any provider who's been seeing that patient. I always tell my palliative colleagues, you take my patient I've seen for 25 years away from you and I will not call you again. So it's not the issue. The issue is to share responsibility, understanding how to manage these patients. And palliative medicine has been having team play since the beginning of time. We understand how to work as a team. We understand each person's role. We understand if you just have a quarterback but no team, you have nobody to throw to, nobody to hand the ball off to. And there are people in palliative medicine that look at metrics that are different than what we look as family physicians, such as what's the professional care standards for the caregiver? And does that matter in the care of the patient? And how do you reconcile the family differences and the ethical resolution of the care for the patient as they approach the end of life, and that patient's going to transition onto hospice from an outpatient palliative program? Does anybody have those types of things running from a professional standard, not an emotional standard, but from a professional standard in your groups? And we created the professional standard. So we actually have more programs than just the programs up here, but we looked, the first research article was just looking at congestive heart failure. It was low-lying fruit. But we looked at cancer, COPD, heart failure, and dementia. A lot of people said, well, you can do this for all of the organ system diseases, but dementia is a little bit different. We said, no, we can do this for everything, because the philosophy of palliative and patient-centered care has nothing to do with the organ system we're treating. The inclusion criteria is that these patients had to be on Medicare Advantage. We had to know the date of death. We propensity matched 3 patients, usual care and sharp health care, because Brian had access to the Medicare decedent index, which we didn't have, so we could look at patients in the system that were not a part of our Medicare Advantage patients. And then we looked at their claims data. These are all the variables, the matching, the predictor variables, outcome variables, outcomes assessed from transitions. And then we looked at the data sources, shared extracted data, patients with claims for more than 1 or 4 diseases, those with the time interval, and the costs were standardized to 2014. So these are the sample characteristics of the research of an innovative model that standardizes its care. But the standardization, by the way, for these patients is only 2 things. Is the patient getting the care they want, and is the patient being prevented from suffering? Those are the 2 standardizations. That's our metrics. Everything else doesn't mean anything. We looked at the age of these patients for cancer, for COPD, for dementia, for heart failure. You can look at the male or female, the propensity charges, that's before they were on service. My statisticians told us that these were all okay. Days to death, so you're going to see the numbers that are coming for cost savings by providing patient-centered care, 4.8 months for cancer and 7.2 months for all of the other diagnoses. And these are the hospital charges saved. So I'm not sure I would want to be, I don't know how you pay for your program at UCSD, but my patients don't get in the hospital. And so there's no RVU to create to pay me more as a family physician. You have to pay me for preventing the patient from getting in the hospital in the first place. Because that's how you keep patients healthy and happy. And for a geriatric patient, what happens when you put them in the hospital for the week? It's 2 weeks in the nursing home. And you took 3 weeks of their life away. And that is not a good experience for any of them. And so you can look at some of these numbers. These are the hospital cost savings. Those are huge. So you would multiply cancer by 4.8 and COPD, heart failure, and dementia by 7.2. A lot of people say, well, hey, you're going to save money because you're spending more money in the outpatient environment. That is also not true. We were saving money in the outpatient environment because they were managed better. And for the first time in healthcare, we were aggressively attacking those issues like caregiver emotional status, like family reconciliation, like resource utilization, 24/7 ability. We've heard all these things for the last 5 hours. We did it in the patient's home. Kept them where they wanted to be. This is the total cost savings. So, if I was in Tennessee, and you're all fee-for-service, and I had 100 COPD patients, what's the cost savings for 7,464 minus 2,805? And it turns out to be about $33,000 cost savings per patient. If you have 100 COPD patients, that's $3.3 million. I'll give you $2 million to take 100 COPD patients if you'll enter a shared risk contract. Could you do that? And if you would, then you find a different type of practice going on, and these patients would be managed better. I'll tell you something I don't say a lot, but I'm going to say it today, is in my own personal practice, I do not remember the last time I had a heart failure patient admitted to the hospital. This doesn't happen anymore. Because we taught a professional skill of how to recognize when the patient's at risk of starting to use the hospital as a tool to manage their advanced illness. And you've all seen that. That's in fact where this program started. I would sit in front of my patients as a family physician. I know I'd done everything I'm supposed to do for them. I know the specialist I'd consulted had done everything they were supposed to do. But I'd send them out the door in fee-for-service knowing that because they didn't have a Medicare Part A skilled need, I just had to hope and pray they would make it back to see me, although they're more likely to be admitted to the hospital. Now, I don't wait for them to get admitted to the hospital. I simply put them on a program that keeps them from being admitted to them in the first place. And that's cancer, that's dementia, that's COPD, that's everything. My bed days per 1,000 are around 100, if that's interesting to people who know what the national standards are. This is the slide that is a paradigm shift and brings a tear to my eye. Because what this says is that we have the potential to manage patients in this country where the majority of the time they will never see the inside of the hospital in the last year of their life. It's not necessary. All of the reactive care that we consider the standard of care for which we get reimbursement in fee-for-service is gone. And in heart failure, you say, well, 44% of those patients are still being admitted. They're not being admitted for heart failure exacerbations, they're being admitted for falls. We have maintained a 90 to 94% reduction in heart failure exacerbations for 10 years. Not zero, but pretty good. These are the percent of patients dying in the hospital. I show this slide, especially because when I talk to hospital systems, I point out that if you want to fix the problem of death in your hospitals or death in your ICUs, you can't turn to the ICU to fix the problem. You have to look silos upstream. And if you're not partnering with your other silos to fix the problems where they occur, you're not going to fix the problem. Unfortunately, we work in a hospital system that has the ability to look at the silos upstream to keep these issues from being a problem. Now, do you think I want to lower these blue bars any further? The answer is I don't. Because the real question is, and I told you the two metrics we look for is providing patients the care that they want, and some people do want to die in the hospital. We're not against that. That's okay. But when you provide patients the care that they want, this is what you get. So there's your total cost savings. You have to add in, of course, the cost of the program. You have to recognize that we're Medicare Advantage, so you get paid less when patients are transferred onto hospice. This is not a hospice program, it's a pre-hospice program, and you have to add in the hospice costs, and we're still saving about $30,000 per COPD patient, $25,000 per heart failure patient. Patients move across the spectrum of need, so they go from our case managers to our transitions program to our hospice program, and then their demise. And then they're not released either. There's still bereavement programs for the family for a year after the patient's gone. And that's a huge transfer issue of patients to hospice compared to national standards, which are about 50%. What about patient and family satisfaction? This is a Likert scale. We only accept 5s. If you had a 4 up there, the lowest number would be 94%. So we wouldn't, we're still working on these. We want these numbers to be higher. It's hard in end of life because people are dying and they're getting sick a lot. And so even with proactive management, they don't feel good. So it's a progression where we really need to be able to do, and we tried to do it, except then suddenly the Medicare Pioneer ACOs came in and they changed the metrics that we were studying this. It's the progression of patient decline. We hope that this would be better than usual care.
Did you also survey the caregivers, families?
Yeah, this is, if we can get this from the patient, these are from the care, usually from caregivers, because some of the patients couldn't respond, so family responses.
On behalf of the patient, though?
Yes.
Did you get family responses on behalf of themselves? Or is that included in that? Which is, you know, like as a caregiver, was I happy with the program for my husband or whatever?
That's all included in here right now. We haven't broken it out. It's hard because as you're doing this process, sometimes the patients can't respond and then they decline and they demise. These are the limitations. The slide deck's available. You can look at the limitations, but I want to talk about the second program that we're creating. This is the program that's getting a lot of national and frankly international attention because they want to know how to move away from using the hospital as a tool to manage advanced illness. That's an archaic residual of what I should consider should be a bygone era. And that's a construct change about the humanity of healthcare. That's real healthcare change, not medical management. I mean, this is taking care of patients in a different way. And we've come to a time in healthcare where we're sophisticated enough culturally to realize that our cultural standards are 60, 70, 80 years old. So these are the conclusions. There's a lot of money. This is all the technical stuff you would put in a research article. I want to show you a few other slides here. This and another important slide, just to give you some more data, just so people want to look at metrics. You know, if you look at the number of hospital days on the bottom, we said we dropped it by 40 or 60%, but the bed days are even less if you're trying to save money and convince your systems or you want to bargain with an insurer to give you a program to create a shared risk contract. And by the way, I know some of the insurers that are begging providers to come to them to create these contracts. Tori, if you're with, I don't know if Blue Shield goes down to Tennessee, but Tori Fields, they absolutely work with you to create a program like this in your area. Especially they want to go to these 100% fee-for-service areas because they realize the benefit of fixing these problems. Number of hospitalizations, dramatically less, about a third. Number of hospital days, you can look at that, dramatically less. 30-day readmissions, we're talking about a third. These are all the metrics that the hospital is getting punished for. So theoretically, even in a fee-for-service market, you could potentially convince your providers, your hospitals to work with you. Palliative medicine is about cost avoidance, so the problem with palliative medicine is you're not going to do any E&M charging by hiring somebody to bill for their services. You need to subsidize them in some way to create the cost savings. So here's the secret sauce. We have 24/7 service. We understand the value of prognostication. We give full disclosure to our patients about the risks. And we, physicians and providers need moral resolution as well. And the reason I say that is a lot of providers, when we're working with them starting these programs, we do what we know. And especially specialty providers, they don't do what they don't know. And we're used to, habituated using the hospital as a tool. And I still see people who say, God forbid they say this, and I've heard this, is, well, everybody deserves to be hospitalized once.
A trip to Disney World.
Yes, right. Yeah, because that's where the great care is, right? But our job is to make it so they don't need us. That's a hard concept. Make it so our patients don't need us. Make it so our communities are so healthy, they don't need us. And if you can do that by managing disease so they don't need us, your RVUs go away, but your quality of care goes up, and it's much more patient-centered. So in the evolving economic models, I think this group knows that. There's efficiency models, and then there's fee-for-service, productivity model. The more you do, the more you get paid. The more efficient you are in managing your patients, the more you get paid. I listened to the macro talk, and I'm thinking, from an economic standpoint, we are starting models of care that are just going to blow your mind in cost effectiveness. Case-centered models for surgery, I'll talk about that in just a second, and some other models that are so cost-effective because we've changed the way we look at healthcare. So we're changing the healthcare construct, reactive versus proactive care. Solution to the problem may not exist in the silo where it comes from. We own the aftermath of our care. I talk about that all the time. If you let a patient get admitted to the hospital that you could have been prevented from being in the hospital, you own all of that aftercare. Now, it's our responsibility as providers, from my perspective, to keep our patients as healthy as possible. Sometimes the best care is no care. That's hard. It's really hard to talk to an insurer. I want you to pay me for doing nothing. Because what I actually did was keep the patient from costing $500,000 or $50,000 or whatever it was. Just give me $10,000 for doing nothing and we're done. We need to stop telling ourselves we can't prognosticate. When we start believing we can prognosticate again, you can get to a treatment protocol such as these. So, as my colleague would say, as you deal with advanced illness patients and you deal with death, it takes a very significant amount of bravery for individuals to tell a patient that they're terminal. That's a problem we still have in healthcare. And I would also say that it's even harder for institutions to tell their patients that they're terminal. When was the last time an institution advertised, we're going to tell you when you're done? And this doesn't happen. So the future's here. We have a lot of programs starting. These are some of them. Actually, I wrote these slides quite a while ago, but we were working with value-based purchasing contracts in nursing homes because they're now responsible for 90 days after discharge. I started doing gero-palliative anticipatory care, but that was too hard of a concept for institutions to understand, so I'm going to show you what that evolved into. And we have an advanced illness ACP program, advanced care planning program, that anybody in our institution can consult on to have the patient and family discuss what their goals of care are so that the care we're providing is consistent with the goals of care of the patient and family. So part two, people say, well, what's coming next? I'm going to read something to you. Part two is about how to identify the stage of advanced elderly, to qualitate and quantitate hospital risk and surgical risk. But I want to read something to you because I think this might surprise you. This is from the American Heart Association, American College of Cardiologists, and the American Geriatric Society, just published a couple of months ago in JAGS. Anybody read JAGS besides me, kind of the area of healthcare I work in? So there's knowledge gaps in cardiovascular care in older adults, a scientific statement from the American Heart Association, American College of Cardiology, and American Geriatric Society executive summary. The incidence and prevalence of most cardiovascular disorders increase with age, and cardiovascular disease is the leading cause of death and major disability in adults age 75 and older. Despite the effect of cardiovascular disease on quality of life, morbidity, and mortality in older adults, individuals aged 75 and older have been markedly underrepresented in most major cardiovascular trials, and virtually all trials have excluded older adults with complex comorbidities, significant physical or cognitive disabilities, frailty, or residents in nursing homes and assisted living facilities. Well, that's what I've spent the last 30 years dealing with. That's interesting. Those are the patients I take care of. As a result, current guidelines are unable to provide evidence-based recommendations for diagnosis and treatment of older adults typical of those encountered in routine clinical practice. How many people knew that over the age of 75 that there was no evidence basis for practicing cardiovascular care besides me? You knew that. And why is that? Because we deliberately excluded those patients from research. Deliberately. Now, we have to go back and find out how to do it right. But this article, so I fell out of my chair for the first part of that, and here's the second part that made me cheer. A pervasive lack of evidence to guide clinical decision-making in older adults in cardiovascular disease was found, as well as a paucity of data on the effect of diagnostic and therapeutic interventions on outcomes that are particularly important to older adults, such as quality of life, physical function, and maintenance of independence. Program number 2. How to tell when you put a patient in the hospital and you're going to take their cognitive or functional status away or take their independence away. We are institutionalizing that process at CHIRP. It's beginning, it's in its infancy, but it will change the way that we practice care. And we've already started that process. So anyways, I'm not going to show you what we're doing, just talk about what we're doing. The objectives that we will need to be asking our systems is, can you name hospital side effects? How many people know more than 5 or 10 hospital side effects? Because there's easily more than 20 hospital side effects for the geriatric population. And as they get older, they're more susceptible to their side effects. And some of them are iatrogenic, and some of them are just not reversible. What's the most common side effect of a patient, advanced geriatric patient being admitted to the hospital? Delirium. And delirium is associated with what? Permanent cognitive decline, permanent functional decline, institutionalization, and premature death. Since we can quantitate their risk, shouldn't we be proactively managing those patients and saying, do you really want to have that hip replacement? I know that arthritis is a little tough, but you have significant risk if you go into the hospital. And does your hospital have a system to treat them should they choose to move forward that's different than the usual healthy geriatric patient? So these are some of the questions. You know, does your system differentiate between physiologic and biologic age? What systematized evaluations, protocols, pre-hospital protocols? Has your system developed a professional skill to tell a patient why treating them in the hospital may be more harmful than aggressively treating them in their place of residence? And understanding how to look at a differential risk for a geriatric patient, an at-risk geriatric patient, and say, what does it mean to you? I have plenty of patients, I think we all do, say, never put me back in the hospital. And you know, I always find that kind of a funny thing, because I think they've been telling that for years, but we haven't understood why they actually get worse in other areas when they're hospitalized. We have to start looking at patient-centered quality metrics, maintaining cognitive status, functional status, avoiding institutionalization or becoming an emotional or financial burden to patients' families. Doesn't matter how good you are at nursing homes. I'm extremely good at that. I shouldn't be doing that for my patients if it's not necessary, and I will if there's another place and lots more RVUs. But my purpose is not to generate RVUs. Some of the problems that we have in healthcare: we're unaware of the innate harms of hospitalization for the advanced elderly. We have persistent medical and family paternalism, lack of medical evidence to support continued use of care for a younger and healthier geriatric population on the advanced elderly, persistent false belief that the hospital is the best care to manage these patients, persistent ageism, and models which reward over utilization. So the action items: Patients, providers should be able to discuss the nature and care provided in different demographics, should be aware of the importance of decreasing polypharmacy, understanding anticholinergic burden issues, understanding the different psychosocial issues and personal issues of the advanced elderly. All these issues are up here. You can read those as easily as I can. And these are some of the skills that we're teaching to providers, how to prognosticate, what to see in patients before it happens. Can you have these discussions with your patients before the inevitable adverse outcome occurs? We should all have patients in our practice for which we've had these discussions. The surgeon said, you can go ahead and have the surgery, and the patient has said, now that you've told me the whole story, I think I'm just going to keep things the way they are. So that's my story for today, and I hope that raises some intrigue. I hope that addresses a lot of the issues that we talked about this morning. So.